This is the current status. This is the some milestones. As we all know, 1995 polio essay launched, 1997 AFP surveillance initiated, 2001, 1999 last case of wild polio virus 2 in UP and Aligarh. 2001, 14 states and union territories were declared free of polio. Last case of wild polio virus 3 was in Jharkhand, Pakur, and last case of wild polio virus in Howrah, and 2012 India removed from the list of endemic countries. But the risk remains, as we discussed. In status of West Bengal, in last 10 years, we got 103 cases, and they are mainly clustered in 3 pokas. In Calcutta, South 24 Parganas and North 24 Parganas, this is one cluster. Another cluster is Murshidabad, Malda, and a small cluster in Asansol municipality of Bardhaman. And what is the common? Among 103 cases, 101 were Muslim. Of course, it has no relation with the religion. The relationship is here. Vaccine avoidance behavior of the community. Among all the cases, 42% did not get any single dose of polio vaccine, neither from routine, neither from pulse polio program. And only 91% got only 4 or 5 doses. So this was the main reason. Along with that, other causes also, quality of activity, migration, but in last few years there tremendous progress, and we were able to stop the transmission. But the problem is our complacency. The government, as there is no polio case, our government counterpart and all the stakeholders may become complacent, and it can hamper the quality of activity. And there is always risk of international importation. Along with that, if there is any gaps in AFP surveillance system, or there is delayed and inadequate response to importation, immediately where we get polio cases, we immediately do the pulse polio immunization, which is called mop-up round. If there is a delay, it will help spreading the transmission. There is also few clusters of areas with low population immunity and vaccine avoidance behavior. So these are our risks. So what will be the strategies? Before that, let me remind you that polio eradication does not mean the elimination of the disease. It is the global interruption of the transmission of wild polio virus. As we all know, the paralysis is unusual manifestation of infection. If we get one paralytic poliomyelitis case, there will be around 200 cases with abortive illness or asymptomatic case in case of wild polio virus 1, and around 1,000 cases abortive illness or asymptomatic infection in wild polio virus 3. But these cases will also transmit the virus. Our challenge is to detect the AFP surveillance, to strengthen the AFP surveillance, to help detecting wild polio virus transmission in this group. So our strategy still stands on 4 pillars. Number 1, strengthening routine immunization. In future, number of supplementary immunization activity, that means pulse polio program will be less as there is no polio case. So we have to strengthen the routine immunization. Along with that, immunization day, both National Immunization Day and the Sub-National Immunization Day. Mop-up round in response to wild polio virus. But last but not the least, surveillance, which I am now discussing. Now, what is the AFP? AFP, let me read first. Sudden onset weakness and floppiness in any part of the body in a child under 15 years of age, or paralysis in a person of any age in which polio is suspected. All cases of acute flaccid paralysis should be reported irrespective of diagnosis within 6 months of onset. Now, sudden onset weakness in any part of the body, not only limbs. It might be facial palsy, it may be parietal palsy, any isolated cranial nerve palsy to be reported as AFP case. Under 15 years of age. But along with that, another thing, paralysis in a person of any age in which polio is suspected. If the clinician suspects that it is a case of poliomyelitis, even the child's age is more than 15 years, you can report it to us. You may become suspicious if the person complains of fever with asymmetrical paralysis, patchy paralysis, descending type of paralysis. If you suspect this, you can inform us that though the age is more than 15 years, but I think it might be polio case, you can investigate. And irrespective of your diagnosis might be compressive myopathy, or your diagnosis may be SOL, your diagnosis may be infantile hemiplegia or meningoencephalopathy. But this is a syndromic approach. If there is weakness in any part of the body, please report it to us as AFP case. Report if there is current flaccid paralysis, even if there is history of flaccid paralysis. Suppose the child has come to you and mother is complaining that child was not able to sit yesterday or limping or was limping 2 to 3 days before. Now the child is all right. Mother has come to you with some different complaint. If there is history, because polio may also cause transient weakness. So if there is history of flaccid paralysis in the current illness, please report it to us. And if you are confused, borderline or ambiguous or doubtful case, whether there is flaccidity or spasticity, it is from the history, it is not clear, whether it will be AFP or not, better report it to us. We can discuss. We'll discuss the case with you. We'll discuss the doctor, it is non-AFP or it is AFP. But if you have any confusion, report it to us. Over-reporting is always better than under-reporting. And report timely, as soon as possible. Why timely? Because while poliovirus discharge uniformly stool sample within up to 14 days. And we want to collect, this is the only means, we want to collect 2 stool samples within 14 days. After 14 days, we'll collect stool samples because there is discharge in the stool sample up to 2 months, but it is not uniform. So we may not get wild polio virus in the stool sample if it is collected, it is collected within after 14 days. So we have to report timely. After 2 months, will not collect stool sample because wild polio virus will not be discharged. To help you, I am just discussing some differential diagnosis, some common presentation of AFP. GB syndrome, transverse myelitis, traumatic, these are classical AFP case. And poliomyelitis is very small font because you will not get poliomyelitis case. But we need to report all AFP cases. Now, these are the borderline cases. Encephalitis presenting with hypotonia, but not in a drowsy or comatose patient. After regaining consciousness, if the mother complains that child is suffering from some neurological deficit, please report it to us. Infantile hemiplegia presenting with hypotonia. Hemiplegia or hemiparesis presenting with hypotonia. Any isolated cranial palsy, facial palsy or parietal palsy. In 2010, there were 8 wild poliovirus cases in West Bengal. Among them, 7 were in Murshidabad. And among 7 cases, 3 were presented with facial palsy. Poliomyelitis can cause facial palsy. It is an established fact. And in developed countries, facial palsy cases were taken as AFP and poliovirus transmission were identified from these cases. But unfortunately, in India, before 2005, we usually labeled facial palsy as non-AFP case, and for this reason, we miss so many transmissions. And in 2010 also, if the doctor could not report this first case was a facial palsy case in 13-year-old girl. If the doctor failed to report this as AFP cases, probably the transmission will be still going on. Residual flaccid paralysis after correction of post-diarrheal hypokalemia. You have corrected the electrolyte imbalance. But even after that, if there is neck flop or weakness in any part of the body, please report it to us It is very common with non-polio enterovirus. These are also neurotrophic virus, Coxsackie virus, ecovirus. This can also cause transient paralysis. Post-ictal paralysis. Usually, in case of torch paralysis, it does not persist after 24 hours. But if it persists after 24 hours of onset, please report it to us. Diphtheritic neuropathy. In fact, any type of neuropathy, post-viral neuropathy, anything, if there is deficient, please report it to us. Transient paralysis and etc. The list is not exhaustive. Any illness, if it comes to you with some weakness in any part of the body, please report it as a case. This is an article published in American Academy of Pediatrics 1957, and it shows that 58 children showing facial palsy during the acute phase of poliomyelitis. Just as discussed that it was an established fact, they studied it, but we have started including facial palsy as a case after 2005. These are some of the some presentations of AFP. The picture will speak itself. This is hypotonic posture. This is a child with left-sided hemiplegia. This is also an AFP case. You have to report it. In initial stage, there might be flaccid hemiplegia. This is a polio case. You can see the abducted left leg. This is a polio case, and this is foot drop right due to sciatic nerve injury. This is a child, Dr. Biswas has investigated this case, child with look the site of injection. It is a case of Metiaburu, traumatic neuritis case. This is very rare, but pathognomonic of poliomyelitis. Weakness of the abdominal muscles, phantom hernia. This is very rare, but only poliovirus can cause weakness of the abdominal muscles. We usually investigate the child in this way. We usually tickle the foot of the child if the child will raise its healthy leg but not the affected leg. Paralysis right valve. This is the case of neck flop. In the year 2008, in Howrah Panchla, there is a polio case who presented with only neck flop. This is a case of paralysis. Child is not able to support its weight. This is also a polio case, abducted left leg, typical posture. This is the first case of the outbreak in 2010 in Murshidabad. The child's name is Rinki Khatun, 13 years old, forearm block, only facial palsy. One homeopathic physician reported this case, and from there epidemic started. We got 8 polio cases in West Bengal in that year. This is a case. We also have to take any isolated cranial nerve palsy case, right heart nerve palsy, ptosis, its medial rectus affected, ophthalmoplegia after encephalopathy, lateral rectus palsy, right-sided. This is also we are taking as a case. These are